Okay, should we make a start? Is everyone okay with that? And if anyone joins late, then that's absolutely fine. But welcome everyone to the first instalment of the ICU critical care teaching sessions that we organised. There's going to be 4 teaching sessions and then 4 reflection sessions as well. We really want to keep them like informal. Please put your hand up, like ask questions as we go. Like I'd rather keep it nice and formal, nice and relaxed. As Denise said, if you could put in do pre teaching survey, that would be great. And yeah, we will have a reflection session on this as well next month. Yeah, so I'm going to share my screen. Hopefully you will be able to see the PowerPoint presentation that we've got. Can you see that?
Not yet, no, it's like a blank screen.
Has anything come up?
No, not yet.
Try again. Anything now?
Yes.
Oh, perfect. That is a relief because my IT skills are poor. Okay. Yeah, so like I said, welcome. We thought we'd organise these sessions. We recognise that in the BRI we're really lucky to have a really established team with established kind of clinical specialists that really help to guide us in our day-to-day practice. And there's probably a need for more standardised OT service across the Southwest and beyond. So we just wanted to kind of be a bit of a place where we can kind of talk about what we're doing and kind of give ideas to others, and vice versa, receive ideas if what you're doing elsewhere is different as well. So yeah, so my name's Charlotte. I'm an occupational therapist. My background is cardiology and cardiac. I've worked across cardiac ICU and more recently in general intensive care.
And I'm Gemma, also an occupational therapist. I work primarily in general intensive care and have for the last couple of years in a static capacity.
We were going to get you to introduce yourselves, but as you've already done that in the chat, we won't ask you to do that. It's nice to meet you all. And yeah, we'll start.
Great, so the aims of kind of today's session is to talk about mobilising service users on an intensive care unit, and that refers to anything that's transitioning them kind of from a supine position and not necessarily just walking. So we're going to refer to the evidence base related to that, kind of how we interpret our medical notes and utilise that to inform an A to E assessment that's the basis of our risk assessment for the therapy sessions we undertake. We're going to talk a little bit about kind of the dynamic risk assessment you do as you'll meet your service user and you enter the bed space, thinking about moving and handling and how we risk assess for that, and also what are the risks of not doing rehabilitation and early mobilisation in the intensive care unit. Great.
Yeah.
Maybe you could try just using that one. There we go.
So a lot of what we'll talk about today will be based on, well, obviously everything we're talking about today will be based on research, but a really nice user-friendly guide to a lot of the things that we're talking about today is on the expert consensus and recommendations on safety criteria for active mobilisation of patients when they're mechanically ventilated and critically unwell. It's a really nice user-friendly document that kind of puts into like a bit of a traffic light system as to when it's kind of low risk to move your patient, when it would be very high risk to move them, and when kind of further risk assessment should be done. Obviously, every patient is an individual and an individual risk assessment should be completed. But this is a really kind of nice guide that looks at lots of different parts of the patient and the patient journey, just to kind of help to guide you in the right place. There's a QR code there, so yeah, if any of you aren't familiar with it, it's a really, really great document to take a look at.
Great. So obviously the basis for our risk assessment comes from our medical documentation, primarily the daily medical review, but then also our flow sheets, and this kind of how yours looks will depend locally on what systems you use, but this is what we will see. So first thing we tend to look at is our vital signs. What's the picture of the vital signs in the last little while? Obviously, we're dealing with incredibly unwell patients who may have variations in this from kind of somebody who is more well and on the ward, for example. So we know what they look like generally, and therefore that allows us to dynamically risk assess in the session. If we see significant variation or change in response to kind of an increase in physiological demand as we're moving somebody about. It can also tell you based off of that whether we're actually in a position where we're safe to start rehabbing. Is their blood pressure adequately stable? Is their heart rate at an adequate level? What kind of rhythm are they in? Is it safe to begin pushing them? Something else we tend to look at quite extensively here is people's blood results. This will tell us kind of their trajectory. Are they improving? Are they stable? Are they getting better? And the things we kind of pay significant attention to is the hemoglobin, the CRP and white blood cells as their infection markers. Are they becoming potentially more septic and therefore are at risk of having variations in things like their blood pressure and their heart rate as a result? We're also going to have a look at kind of their metabolic function and how they're, because that will tell us about alertness, their kind of exercise capacity and reserve to engage in rehabilitation, but it can also be a good indicator of whether we're anticipating somebody to be delirious or not. Other things you want to have a look at are your lines and attachments, because that's going to tell you how many people you potentially need to move that individual, and kind of a risk assess kind of how you're going to manage things like drains, airways, catheters, invasive monitoring lines, and potentially blood gases as well, but that's something we'll touch on slightly more when we do our delirium session.
With all the patients that we see here in the BRI, we will do an A to E risk assessment. This is something that helps to put our risk assessment into a really nice structure and protects you and protects your patient. It's again quite user friendly. So when you're looking at your airway, has that patient got an artificial airway or have they got their own airway? How are they receiving basically ventilation? If they've got a endotracheal tube, then obviously it's important to think about how many pairs of hands you need to monitor that. If you're mobilising your patient, when I say mobilising, I mean kind of moving them in any form, whether that's rolling them in a bed or sitting on the edge of the bed, someone will need to be holding that endotracheal tube to make sure that it's kind of safely in position. In terms of if you're ever moving someone with I said it the wrong way, didn't I? Who's tubed and ventilated, you also need to kind of make sure that you're moving someone and holding onto that and bracing it as well, and keeping an eye on the measurement that you've got. So someone's teeth will be at a certain measurement, and they can note that measurement to make sure that tube hasn't moved. If someone's got a grade 4 airway, we always want to be making sure that we've got an extra pair of hands in the room. They should have 4 people to mobilise a patient with an artificial airway who's got a grade 4 airway, and a senior nurse as well, and obviously making sure that your doctors are aware that you're doing that as well. Your breathing would be your mode of ventilation. So if you're thinking about your patient, how they're receiving their ventilation, so whether that's something like SIMV or CPAP, how are they receiving their oxygen, and what is their oxygen saturation levels, and what are their respiration rate. We're also thinking about circulation, so what kind of cardiovascular support that person is on, if any, and how much they're on. That will kind of give you a good indicator of what their cardiovascular reserve is, in terms of how much exercise they might be able to tolerate. It will be things like their blood pressure, their cardiac rhythm, and their heart rate as well. Disability could be things like, usually we'll include things like the Richmond Agitation Station Scale in this, and whether they're CAM ICU positive or CAM ICU negative. Again, if someone is very delirious and CAM ICU negative and they've got a Richmond Agitation Scale of kind of +2, +3, there's a very small chance that you're going to have any kind of therapeutic value with that patient, and vice versa. If they got a RAS of -2, -3, then again, thinking about what therapeutic value you'll add to that patient. You can also think then about your environment and your exposure. So again, like Jen said, what lines have you got? How many people do you need to manage those lines? Quite often we'll be quite reliant on our bedside nurse for those lines and managing them while we're moving the patient around. But if they're not available, we might need an extra pair of hands from the therapy team to be able to do that. Monitoring their vitals in terms of like all of the different kind of like lines that they'll have for that, cardiac monitoring lines, art line, those kinds of things, and whether they're kind of very, very weak. And then we do a risk assessment based on this then. So quite often that will be line dislodgement, monitoring their vitals and support for their airway, but it could also be things like their past medical history, whether they're bariatric and they need kind of multiple people for moving and handling purposes for that perspective, whether they've got a weight bearing status that might mean that they're more limited.
Great, so we're going to show you a little video now of kind of entering a bed space. It's quite short, but as you're doing that, we want you to kind of have a think or jot some ideas down about what you're noticing, what potential risks there might be, what's informing your dynamic risk assessment as you're walking in the room, and then we'll ask you to feedback either in the chat or verbally.
Sorry, I don't know if you can all see the thing that's just popped up there. I don't know how to get rid of it. Sorry.
I'll reboot, I think. Could you see, anyone see that pop up, or did it not get in the way for you guys? Oh, it did. Yeah.
Minimize it.
Yeah, because it's going to stay open for an hour otherwise.
Sorry about this.
It's not moving at all, is it?
How's the mind?
Great. So yeah, that's the video. Any thoughts? Anything you want to put in the chat or speak aloud?
Yeah. Oh, can you hear me?
You're quite faint, I think.
Can you hear me now?
Yeah.
Yeah. There were some PP instructions on the door just before we went in. There were quite a few things ticked.
Yeah.
Yeah,
great. Anything else?
The airway had a trachea.
Yeah.
There are lots of lines.
Yeah. Any particular line that would worry you?
All of them right now.
need
Need a closer look.
The filter.
Yeah. So the bass cap is the one that's often can be quite tricky and quite temperamental in rehab particularly, and we don't have the skills and the competencies within and kind of an integrated OT-PT team to manage that. So you'd be thinking about wanting your bedside nurse present for anybody that's filtered. So yeah, we got most of them there. So the infection control precautions are obviously written up on the door. So you want to think about donning appropriate PPE, kind of do a brief end of bed assessment. Obviously we've got a mannequin there, but you'd be kind of walking in, looking at your patient and thinking, does this represent the individual that I'm thinking I'm coming in to see based off of the notes, their anticipated GCS, etc. Got monitoring attached. You can see the mean arterial pressure was a little bit low there, so you might want to be keeping an eye on that as you're moving, just so that it doesn't drop below their intended target, which is usually around 65. Got multiple lines and attachments, particular concerns for the filter and the tracheostomy, although at that point they're having oxygen in train through a trache mask rather than being on the ventilator, so it's slightly less risky. And at that point, there isn't a bedside nurse in the room, but for this patient, you would want your nurse there, certainly. Cool.
We'll move on to the next one, which is also a video. This one's a little bit longer.
I don't think the sound's working.
I'm sorry. Was it working for the last one?
No. There's no talking in the last one, it would have just been like a static
right, okay.
sound. But...
How do I do that?
Maybe if we try muting ourselves and then play it and see if that works.
Good idea. Could you hear that the second time? No.
We've done the enable sound toggle, so hopefully this should work now, but shout at us if it doesn't.
Hello.
So my name's Libby. I'm one of the practice educators in general ICU in the BRI. I'm going to have a little chat through our patient today and just let you know about all the different wires and airways that this patient has got attached to them. So we're going to start with the airway. This patient's airway is a tracheostomy. As you can see, the patient has got some oxygen on at the moment via a tracheostomy mask. This patient also has a speaking valve on, so I'm just going to remove to let you see. So this is what a normal tracheostomy would look like without a speaking valve. Tracheostomy comes in various sizes. This particular one is an 8. They are secured by ties and normally have a dressing underneath. They also should all have an inner cannula in, which is a little ring pull here. Twice a shift, this inner cannula will be removed, cleaned, and then replaced back into the patient with a little click. These inner cannulas are to help if you are worried that the patient has any kind of obstruction that you can't suction out. So they're a safety precaution, they should always be in there. They also have a couple of wires attached to them. So this port here is your subglottic port. The subglottic port sits below the balloon, which is attached to the tracheostomy, and protects the airway from secretions. A couple of times a shift, depending on the patient's secretions load, a nurse will attach a syringe and pull back on the subglottic port. There is a hole above the balloon and they can pull back secretions from there before deflating a cuff. Cuffs are normally inflated unless the patient is on rehab. To deflate the cuff, you attach a syringe and pull back. The cuff will then look flat. If you've been asked to place a speaking valve or a passenger valve onto your patient, you must make sure that the balloon is deflated. When a patient doesn't have a speaking valve, the patient can inhale and exhale via the tracheostomy. Once the speaking valve is placed, the patient, this is a one-way valve. This valve slams shut on exhalation and the air is pushed up out of the mouth. If you have not deflated the cuff of the balloon, the patient will not be able to exhale and the patient will start to deteriorate. They will not be able to breathe out and their chest will hyperinflate. So it's very important that even if you come to a patient and the balloon looks flat, still place a syringe to the balloon and just check that there is no air in it. If your patient is struggling to breathe at all, for any reason, the first thing you would do is remove your passenger valve. And then you would look to your nurse for suctioning or to remove the inner cannula to check if there's any obstructions. The patient should be able to have some voice when this speaking valve is in place. All tracheostomy patients should have one of these sheets hanging by the side of their bed. This sheet tells you whether or not the patient has a surgical or a percutaneous trache. A surgical tracheostomy will have sutures on either side. These are called rescue sutures, and they are there so that if there's any problems and the tracheostomy falls out, you can pull the sutures down and out, and it pulls the trachea to the front of the neck so the patient can breathe before another tracheostomy is inserted. Percutaneous tracheostomies are put in via dilators on the unit. These do not have sutures, but both surgical and percutaneous trachees will be seen on the unit. Tracheostomies are thought of as high risk when they have just been placed or if they have an adjustable flange, which is a longer tracheostomy. And for various other reasons depending on your patient, so if they're swollen and they have a difficult airway. This sheet will tell you when the tracheostomy was put on and what type of tracheostomy it is. On the back of this sheet you will find the emergency tracheostomy management. This is the algorithm, national algorithm, to be followed in the event of a patient having difficulty breathing with a tracheostomy on. So if you find this happens, you can grab this from wherever it's hanging and just turn the sheet over and also pull the emergency buzzer so you can get help. In the patient's bedside, they should all have a tracheostomy kit. This is a big blue box. This kit has tracheal dilators and different size tracheostomies and anything you would need in an emergency situation. If you're going to mobilise your patient and they have a tracheostomy or they've had a tracheostomy in the last 24 hours, this box should be taken with them when they are being mobilised or out to the garden.
Is there anything there that anyone would like to ask or discuss, or any comments? So yeah, so we just covered the type of tracheostomies, difficult airways, emergency procedure, and handling an airway when you're mobilising a patient. So like I said, always having kind of hands-on stabilising that airway whenever you're moving a patient with a tracheostomy, and which we'll show in a video a little bit later. We've got a separate video now on lines and attachments, so we'll play that.
We're going to move on to the cardiac lines now. So this is a central line. You will normally find these in the jugular vein, which is coming out of the patient's upper neck here. They have lots of attachments. We normally have Quinn lines, so they have 5 of these attachments on them. And quite often, they will be attached to medication that you cannot remove. Please seek nurses' support for any removal of medication. You can also find central lines in the subclavian, so you would find them just underneath the clavicle here. And the other place you might find they have a central line is femoral, down here. These can be a little bit more tricky when you're mobilising because the wires can get in the way, obviously, when they're bending their legs. If they've got medication that needs to be continually infused, you might find that that can be a difficulty. Our patients will sometimes also have cannulas. These can be placed in all of your standard places, over arms and legs. And again, if you want to find out if anything can be detached, please just check with the nurse at the bed space. Our other cardiac line that we have is our arterial line, which is over here. So arterial lines are used to continuously monitor blood pressure, as well as to take arterial blood gases to check on the patient's condition. You will find an arterial line attached to either your radial artery, which is in your wrist, your brachial in your elbow. Again, you can have femoral ones, which are a little bit more difficult to mobilise with, and even more difficult to mobilise with. Very rarely you may find them in the foot. With arterial lines, the main thing to remember is if you have a drop in blood pressure, if you have a look at the screen now, the red line there and the red numbers are your blood pressure. You can see that you have a really nice clear trace with a dichrotic notch, which is the little blip after the tallest peak. This shows that you've got a really good blood pressure reading. If the blood pressure reading does not look like that, your blood pressure might not be accurate, so check with your nurse. Other reasons whilst mobilising your blood pressure might not be accurate can be that your transducer clip, which is here, is not in line with your axilla. If your transducer clip is not in line with the patient's heart, then the blood pressure will either read higher or lower than the patient's blood pressure. So again, if you're worried about their blood pressure during mobilisation, it's good to check these things and check with your nurse for help.
Great. Any questions, concerns about that one? I think something that wasn't touched on there is your nasogastric tubes. Those, for the most part, at the BRI, we disconnect for rehab unless the patient is insulin dependent, just because they're so prone to falling out and, of course, really uncomfortable to put back in, but are super vital for delivery of kind of enteral medications and feed as well. So I don't think Libby talked about those, but that's the only other one to probably mention. this is another little video just about drains and the type of kind of drains that you might see attached to patients and some of the concerns we can have around moving those.
Before mobilising, it's worth remembering that patients might have lines that you can't see initially. So always just check with the nurse or check with your patient if they've got any drains. This patient has a Ready-Vac drain following surgery. In this case, I would just highlight how much fluid was in the drain to the nurse, just to check that this hasn't just happened all of a sudden when you've moved the patient. And I would just check that the dressing is not sodden and secure before moving around, just to make sure the patient is going to be stable. The Ready-Vac drain is done on a vacuum system, and you can find a Ready-Vac drain in various places on the patient's body. So if they've had MATSAC surgery, you might even find it coming out of their mouth or neck, but most likely to find it in their torso, so chest, abdomen. The other types of drains you might see on ICU is you might see back dressings, which you probably also see on the wards. These come with a little bag. You might find topaz drains, which are a type of chest drain. Again, you can carry this with the patient and they have a battery life. Or you might find something called a rocket drain or a gravity drain. This is another type of chest drain. This chest drain works on gravity, and the most important thing to remember with it is that it cannot be lifted above the patient's chest height. If you need to pass the chest drain over a patient because you're mobilising them to the side of the bed, you will need to pinch the tubing, not to clamp, but pinch the tubing, move it over the patient, and then once it's back below the patient's chest height, you can release the tubing. It is very important that you do not clamp these tubes, as if they get left on, it can cause the patient to deteriorate.
Great, so I think that pretty much covers everything that's on the bullet points on the side there. Drains can be tricky. One of the things we make sure that we do is check how the drain is secured, that it's stitched into the skin adequately and that it's well dressed before we get them moving. We also use the blue clips. I think you can see hanging in the back of the bed space for any kind of abdominal drains that can be, we essentially clip them onto the gown so you know they're staying with the patient as we're shifting and we're moving. So yeah, I think the other thing that Libby probably didn't touch on with the water drain is that you want to check you've got a swing so that as the patient breathes in and out, you're seeing a change in the water level in response to that breathing, and that tells you that it's working adequately. Great.
So we've got a couple of videos now which kind of just show a bit of a role play really of moving a patient, what that might actually look like. So yeah, we'll play those to begin with and hopefully they work.
Come in. Hi. Oh, hi.
Hello, Libby. Hi, Mrs. Smith.
Hi, Charlotte.
Hello.
Hi, Gemma.
It's Gemma and Shah from the occupational therapy team. We're going to get you moving today, my friends. We're just going to catch up with your nurse before we get going. Apologies to talk about you briefly, okay? We are hoping to get Mr. Smith sat up on the edge of the bed.
Brilliant.
Have a look at his strength and his ability to follow commands and things, and then probably back to bed afterwards if you're happy.
Yeah, that's great. Do you need a hand?
It would be really great if you were able to help. If
Yeah,
there's
no problem.
any medications or anything that could be detached, that would be really helpful.
So the only medication he's got running is noradrenaline, so I can't detach that. His blood pressure is a little bit borderline.
Fine.
But I think if you're happy, I'm happy for him to be mobilised.
And if we put the filter on care mode, are you happy to look after his...
Oh, absolutely, yeah.
Thank you. And happy for me to pause NG and take that down?
Yes.
Great, thank you so much.
He's not on any insulin, so that should be fine.
Okay, I'm just going to start moving the beds a little bit. You might feel the bed moving underneath you.
Do you want me to recirculate the filter so we can detach it completely?
That would be helpful if you, if that's possible.
Yeah. That'll give us 20 minutes.
In that case, then, are you happy to look after Aunt and I before a bit more about blood pressure?
Absolutely.
Amazing, thank you so much. You're just going to feel the bed moving now, just as we get ready to help you have a sit up. head of the bed up just to look a bit. And the mattress is already on firm. Yeah. So plan B is you bring legs this way, you do a slight roll towards us, this is where most of our lines are, and then we'll have a sit up all together. Is everybody happy? Yeah, perfect. I'm going to find the shower from behind you, you're looking up at our line.
I am, yeah. His oxygen's not got a huge amount of give on it, but I might just move this a bit closer.
This is this. While Libby does that, we're going to help start to get you moving. What we're going to do today is have a sit up on the edge of the bed and just see how your tummy muscles and your arms and your legs are working. All right, Mark? Okay. So you're going to join in with me. We're going to move this leg towards me, towards the edge of the bed. Join in if you can. And same with this right leg. Okay. Sorry. So we're going to help reach this hand over towards me now, to this side. You're going to have a roll over. Steady, steady roll. And this is we're going to help you sit up, okay? Everybody happy? Steady, steady, sit. Just bringing this hand forward slightly, yeah. Get that outline in the right position.
You've just got a follow-up video to that as well, and then we can chat about what's on the video.
We have Mr. Smith sat up on the edge of the bed now, and I start to do my own internal risk assessment. I have a quick look at the monitor to make sure his numbers have stayed stable and there's no changes we need to make to the delivery of oxygen. Check that the outline is in the right position, so we've got an accurate blood pressure reading, and that all of our ECG dots are still attached to the monitoring. We have a quick check over to the opposite side that we're sat up from to make sure there are no lines that are tethering or pulling and potentially putting Mr. Smith at risk. And same with any lines on this side here, that they're all still in the right position and attached securely. And that our drain is in the right position, that we're stable on the edge of the bed, feet are on the floor, and the shower is comfortable and able to hold him up appropriately.
Are there any thoughts or questions or anything around those videos? Does it look kind of similar to what you might see in your own ICUs?
Yes, it does.
Yeah. Okay.
Okay, and we're dealing with a really complex, high-risk cohort of patients in the intensive care unit, and completely understandably from kind of new starts within the team and also other members of the MDT that we're working alongside, there is anxiety about moving these patients and the potential risks that we put them at by doing it, but there are also so many risks of not doing it, and so much that we know about post-intensive care syndrome and what survivorship looks like for these service users that we can use to advocate for our roles and why we do what we do. So we know that anywhere kind of between 35 to 90% of service users suffer with ICU-acquired weakness, and that kind of can persist for up to a year post-discharge, impacting their ability to engage in the things that are meaningful, but also puts them at greater risk of further illness and therefore readmission to hospital. We know that therapy and early mobilisation is the only kind of good evidence we have related to management of delirium. All of the other kind of delirium management strategies that we use day to day has got kind of weak evidence related to it. So our role is super important in managing even what can be quite an agitated, potentially risky cohort of service users to move. We know that, of course, if somebody is weaker and functionally more dependent, they're going to remain in hospital for longer. They're going to have higher utilisation of kind of social and primary care resources after they leave hospital. But also the longer they stay with us, the greater risk they are of another hospital-acquired infection. And of course, they're so vulnerable to becoming unwell again because they've already got significantly reduced physiological reserve compared to a general patient population. We know that patients that leave the intensive care units with a Manchester Mobility score of 5 or less, which is transferring with assistance, have are less likely to return to their baseline ability, and they've got poorer longer-term functional outcomes. And that being immobilised, dependent, institutionalised contributes to poor psychological outcomes and long-term low mood and potentially PTSD type symptoms. So there's a huge amount of benefits from doing what we do as early as it is safe to do it, even if it can, particularly I think within nursing teams, can sometimes cause trepidation and anxiety. But this narrative is really important in kind of shifting that culture and moving towards a rehab recovery focused culture in our intensive care units, as well as just kind of avoiding mortality, essentially. Right. So that's the slides done. Any questions, concerns, queries, particular things we've not touched on that you'd like to talk through? We've got 10 minutes if anyone's got anything they'd like to bring up.
I just wanted to ask, in the last video that you played, you mentioned care mode. I think it was for the filter.
Yeah.
What does that do? Does it pause it, or?
It essentially gives us a brief pause in treatment. You can't do it for particularly long, so it'll start alarming at you if you're doing a slightly longer rehab session. So it's one option. The best option is, where possible, to recirculate the filter, and our medical teams at the BRI are always keen to facilitate filter holidays in order to enable rehab, so aligning that with the medics and then the nursing team can be really valuable because it can give us a window where we're filter free. So yeah.
Cool, thank you.
James, have you got a question?
No, just to add to that, it's 2 minutes for care mode and it reduces the volume, so you can't keep it for too long because it's not doing its job.
There's not any other kind of, yeah.
Can I just say thank you very much to Charlotte and Gemma for doing this. It takes a lot of balls to do this in front of a region of kind of therapists and peers, so kind of a tremendous job, and I just wanted to say thank you very much. And this is the start really of trying to promote our profession in ICU, so we need to embrace this training because it's going to make us better as a region. So thank you very much to both of you.
No problem. There will be the reflection session in April, if I'm correct. Oh, Sophie.
Yeah, I'll just second what James has said. It's really helpful, and I just wondered, will we have access to the slides and the videos, because I think they'll be really helpful for teaching like other staff members that we have that come into ICU every so often, because they're really helpful and really clear, and yeah, that'd be useful if we are able to use them.
Yes, I think Denise has recorded it and then is going to find a way to upload it on to the ICS stuff. But Denise,
thank you so much. Thank you.
Denise?
Yeah, just to say, it is recorded. You are still sharing your screen, just so you know. We'll try and get it onto the onto this network website, but failing that, is everyone fairly familiar with NHS Futures platform? If we created a page on there, that's really straightforward and really secure platform. So I'm chatting to our administrator next week about whether we can get the recording shared onto a website, but failing that, we'll get it onto NHS Futures, and I'll send a link around with kind of the how to access that if you're not already a member.
Yeah, thank you. Sarah?
Yeah, thank you for doing that. That was really good. Just a quick question, like do most people around documenting any kind of risk, do they do it mainly through your own notes? Because that's what I probably do. Like if I highlight any risk or see any risk or need to link in with the MDT on any risk assessment that I might have carried out or that's highlighted during the assessment, I would probably document it in my notes. Is that probably the most common thing?
Yeah, I think it's kind of in any interactions you have in terms of planning someone's treatment. When we do morning allocations, we'll go around and kind of one person will go around for each zone in the ICU and look at kind of what potential risks might be. So if they've got a high risk airway, or they've got lots of lines or attachments, or they've been a little bit agitated, or they're very delirious, anything that makes you think, right, I might need an extra pair of hands here than what we normally have for our rehab sessions. Yeah. We would look at that when we allocate the patient to the therapists then, and the appropriate therapist and the appropriate number of people with the appropriate skill mix. So there's that element to it. But yeah, I think in terms of your risk assessment, I think it's something that we probably think about and talk about as a team before we go and see that patient. So in terms of things like allocating roles and thinking about, if the patient was to acutely deteriorate quickly, what would we do to manage that? And kind of assign those roles before we go into those patients, particularly those high risk patients. So I think it's something we talk about before, and then it's just formally documented in your A to E assessment then in your notes.
Brilliant, thank you.
Okay.
So we've got our reflection session in April, which will be an opportunity to kind of maybe go away, practice some of the bits that we've gone through today, and then come back and chat about any of the concerns that we've got, or have a look at that the paper that Shah popped in with the QR code, which we can email around again if people need it. Have a read of that and come back with any questions. There's so much to cover in risk assessment, so we tried to do just a brief overview, but we're really happy to delve into more in the next one.
Yeah, definitely. Thank you so much for taking times out of your day to come to this. Yeah, I think it's really important, isn't it, that we shout loudly about the value of OT in the unit. So yeah, thank you all so much for coming, and we'll see you.
Thanks, guys.
Thank you. Bye.